Bone marrow stem cell therapy has been the reference point in regenerative medicine for over 30 years. It has the longest clinical history of any stem cell source. It has the deepest evidence base. And when most people outside of regenerative medicine think about stem cell therapy, bone marrow is what they think most often of. So when I tell you that umbilical cord tissue holds clinically significant advantages over bone marrow-derived MSCs that are primarily used in most regenerative medicine office applications, I want to be clear that I'm not dismissing bone marrow's history. I'm building on it. And I want to back every claim up with science, not sales. If you have ever had a patient ask you why you do not just use bone marrow, the most well-known stem cell source in medicine, and you were not entirely sure how to answer that with clinical precision, this video is going to close that gap. By the end of it, you will have a complete head-to-head comparison across every clinically relevant metric and the specific language to use in your next consultation when that question does come up. I'm Dr. Roy Picard with Select Regen Solutions. After 36 years in practice, I made a decision in 2017 to integrate regenerative medicine into my office, where my team and I began offering umbilical cord stem cell products and a full range of regenerative medicine biologics. Since then, I've worked directly with MDs, chiropractors, and nurse practitioners to help them build and optimize their regenerative medicine offices, from clinical education and umbilical cord stem cell product selection to patient communication and practice growth. This is episode 3 of our clinical science series. Episode 1 covered the UC-MSC foundational biology, what mesenchymal stem cells are, how they work, why the paracrine mechanism is the dominant therapeutic framework, and what your allograft supplier must document. Episode 2 went head-to-head between umbilical cord and adipose-derived MSCs. This episode takes on bone marrow. If you're not subscribed yet, do that now. This series is built specifically for regenerative medicine practitioners who want to practice with clinical confidence and communicate with credibility. And what comes after this builds directly on the foundation we are laying here. Before we get into the comparison, let me frame why this particular head-to-head matters so much for regenerative medicine practitioners. Bone marrow carries a level of cultural authority in stem cell medicine that adipose simply does not. When a skeptical patient or doubting colleague challenges you on the use of umbilical cord products, bone marrow is often the, let's say, counter argument that they reach for. Bone marrow is the original stem cell therapy. Why not use that? Well, if you cannot answer that question with clinical precision, if you are just relying on some general impressions or supplier talking points, you're likely to put yourself into a vulnerable position during that conversation. This video gives you the clinical foundation to answer precisely, confidently, and without defensiveness. And as with the adipose comparison, we are going to start by giving bone marrow its full and honest clinical due, because that intellectual honesty is what makes umbilical cord mesenchymal stem cells case land with authority, let's say, rather than sounding like some type of marketing exercise. Let's start with what bone marrow has genuinely earned. Bone marrow is the original stem cell source in clinical medicine. Hematopoietic stem cell transplantation from bone marrow has been performed since the late 1950s. The first mesenchymal stem cell isolations from bone marrow were described by Alexander Friedenstein in the 60s and the 70s, making bone marrow-derived MSCs the most historically studied MSC source in medicine by a significant margin. When a practitioner of a patient cites bone marrow research, they are standing on genuinely solid scientific ground. The evidence base for bone marrow mesenchymal stem cell is the largest and the longest running of any MSC source. In orthopedic applications specifically, cartilage repair, tendon healing, bone defect management, and fracture non-union, bone marrow concentrate has a well-established clinical track record. The evidence is real, it is peer-reviewed, and it is sufficient to support reasonable clinical use in the right application. The autologous option is a genuine advantage that bone marrow shares with adipose. For those patients who are philosophically or emotionally resistant to donor-derived products, Autologous bone marrow presents a legitimate alternative. The patient's own cells, no rejection risk by definition, and the regulatory history of bone marrow procedure is the most familiar in all of stem cell medicine. Practitioners, patients, payers, and regulators have decades of experience with bone marrow in various contexts, and that familiarity creates a baseline of comfort that newer MSC platforms are still building toward. I want to acknowledge all of that clearly and without qualification, because dismissing bone marrow's history would undermine the credibility of everything that comes next. Now, let's talk about the harvest procedure, because before we even compare the cells themselves, the process required to obtain bone marrow MSCs is a significant clinical and patient experience liability that umbilical cord allograft therapy eliminates entirely. Bone marrow aspiration, the standard method for obtaining bone marrow for MSC isolation, is an invasive procedure. It is typically performed under local anesthesia and in some settings under conscious sedation, let's say. The most common harvest sites are the posterior iliac crest, the tibial plateau, and the femur, all of which require a needle to penetrate bone under controlled clinical conditions. Let me be precise about what this procedure entails for your patient. Procedural risks include pain during and after the aspiration, infection risk at the harvest site, nerve injury from needle placement, hematoma formation, and in rare cases, fracture at the aspiration site. These are real risks, manageable risks, but risks that must be disclosed, documented, and explained to the patient as part of the informed consent process before any therapeutic injection is even discussed. And then there is the recovery. Most patients experience significant soreness at the harvest site for anywhere from 3 to 7 days post-procedure. In the context of a patient who is already managing chronic joint pain, inflammation, or progressive tissue degeneration, adding a secondary invasive procedure and a recovery period before the therapeutic intervention is a meaningful clinical and experiential burden. There's also the yield problem. Bone marrow is extraordinarily MSC poor relative to what most practitioners assume. Mesenchymal stem cells represent only approximately 0.001 to 0.01% of the nucleated cells in the bone marrow aspirate. This means the overwhelmingly majority of what is harvested, often more than 99%, is not therapeutically relevant MSC population. Concentrating that fraction into a clinically meaningful, let's say, MSC preparation requires either same-day centrifugation to produce bone marrow concentrate or cell culture expansion, both of which introduce processing variables that directly affect final product quality and that are not present in regulated allograft products. And here is the standardization gap that most practitioners who perform bone marrow concentrate procedures do not fully appreciate. The bone marrow concentrate being produced at the point of care through same-day centrifugation, through in-office kits, is not a characterized, documented product in the way that regulated UC-MSC allograft is. There is no viability percentage documented before injection. There is no surface marker confirmation. There is no certificate of analysis. You are administering a biological preparation of unknown mesenchymal stem cell count, unknown viability, and unknown paracrine output, and you carry the clinical responsibility for that outcome regardless of what those unknowns contain. For some practitioners, this is a familiar point. For others, it is the first time that they've actually heard it stated this directly. Either way, it is the clinical reality, and it matters for every practitioner making product decisions in their regenerative medicine office. Now, let me build the case for umbilical cord mesenchymal stem cells head-to-head against bone marrow aspirate. There's 5 specific advantages that are supported by the comparative literature and directly relevant to the application most regenerative medicine offices are treating every day. The first advantage is biological age, the neonatal advantage, and this is the most fundamental difference between UC-MSCs and the bone marrow-derived MSCs when the bone marrow comes from an adult donor. Let me state the core biology plainly. Umbilical cord mesenchymal stem cells are neonatal cells. Bone marrow MSCs from adult donors are adult cells. And in cellular biology, that distinction is not semantic. It is measurable across multiple parameters that directly affect therapeutic potency. Telomere length. UC-MSCs from Wharton's jelly demonstrate significant longer telomeres than bone marrow MSCs from adult donors. Telomere length is a direct indicator of a cell's replicative capacity, how many times it can divide before it reaches its biological limit. Longer telomeres in UC-MSCs means more cell doublings, greater expansion potential, and a longer functional viability window. Shorter telomeres in adult bone marrow MSCs mean the opposite: reduced replicative capacity, earlier cellular exhaustion, and a narrower window of therapeutic utility. Proliferative capacity. UC-MSCs consistently show superior proliferative rates compared to adult bone marrow MSCs. They maintain viability and surface marker expression through more passages in culture, which matters both for the product manufacturing at the tissue bank level and for the biological potency of the cells being administered at the clinical level. Resistant to senescence. This is the point where the practitioners most consistently underestimate until they actually see the cellular biology clearly. As a donor ages, bone marrow MSC shows increasing expression of senescence markers, including P21 and P16, along with progressive reduction in proliferative capacity and secretome output. But cellular senescence is not simply a state of biological retirement. Through what is called the senescence-associated secretory phenotype, or SASP, senescent cells actively release pro-inflammatory mediators into the local microenvironment. In practical terms, senescent cells do not just stop contributing to regeneration, they can actually actively suppress it. UC-MSCs from neonatal tissue show dramatically lower senescence marker expression. They are not carrying decades of oxidative stress exposure. They do not carry decades of inflammatory burden or accumulated epigenetic damage. And that biological cleanliness translates directly into a cleaner, stronger therapeutic signal. Let's consider what this means for a typical patient in a regenerative medicine office. A 70-year-old patient with chronic knee osteoarthritis receiving autologous bone marrow concentrate is receiving MSCs that have spent 70 years accumulating exactly the kind of cellular aging and inflammatory exposure that is contributing to their condition in the first place. A 70-year-old patient receiving a UC-MSC allograft is receiving cells from the biological profile of a newborn. This is how you say it in a consultation. When we use umbilical cord tissue, we are introducing cells with the biological age of a newborn into your healing environment. Your bone marrow has been exposed to 70 years of the same inflammation and oxidative stress we are trying to reverse. These cells have not. The second advantage is paracrine secretome superiority, and given that the paracrine hypothesis is now the dominant framework for understanding how MSC therapy works in most clinical applications, secretome potency is arguably the single most comparative metric. Let me restate the fundamental clinical principle for clarity. The therapeutic benefit of UC-MSC therapy is not primarily driven by the cells engrafting into the damaged tissue and differentiating into replacement tissue. That model is largely obsolete as the primary explanation for clinical outcomes. The dominant mechanism is paracrine. The cells release a complex of array of bioactive molecules called the secretome that modulate the local microenvironment and activate the body's own repair mechanisms. Given that framework, the therapeutic platform with the most potent paracrine output has the strongest clinical foundation, and the comparative literature consistently supports umbilical cord mesenchymal stem cells over adult bone marrow mesenchymal stem cells on this metric. VEGF, vascular endothelial growth factor, which drives angiogenesis and new blood vessel formation in the new repair zone, higher in UC-MSCs than age-matched bone marrow MSCs. HGF, hepatocyte growth factor, which supports tissue remodeling and cellular survival, again higher in UC-MSCs. IGF-1, insulin-like growth factor 1, which promotes proliferation of resident progenitor cells in the repair environment, is higher in UC-MSCs. bFGF, basic fibroblast growth factor, which supports cell proliferation and wound healing, is higher in UC-MSCs. On the immunomodulatory side, UC-MSCs demonstrate stronger production of anti-inflammatory mediators, including IL-10 and TSG6, compared to adult bone marrow MSCs. They show more robust suppression of pro-inflammatory cytokines, including TNF-alpha and IL-1 beta, the primary drivers of the chronic joint inflammation that most regenerative medicine offices are treating every day. And they promote more reliable macrophage polarization from the M1 inflammatory phenotype to the M2 reparative phenotype, the biological shift from a state of tissue destruction to a state of active healing. And then there are the exosomes. UC-MSCs produce a higher quantity and more biologically active exosome population than adult bone marrow MSCs. Exosomes, extracellular vesicles carrying microRNA packages, are now understood to be the primary carrier of the MSC therapeutic signal, capable of modifying gene expression in target cells and extending the therapeutic effect beyond the lifespan of the injected cells themselves. The exosome advantage of UC-MSCs over bone marrow MSCs is not incremental. It is a consistent finding in head-to-head comparative analysis. The clinical implication is direct. A higher potency secretome means a stronger biological signal delivered to the repair environment, which in most applications translates to a more robust and durable therapeutic response for the right patient. If the mechanism of action is paracrine, and the evidence strongly supports that it is, then the platform with the most potent paracrine output has the clinical advantage. And in a head-to-head comparison between UC-MSCs and the adult bone marrow MSCs, the Secretome data consistently favors the neonatal source. The third advantage is immunogenicity, and this is the advantage that most directly addresses the concern that appears most often when practitioners and patients discuss allogenic UC-MSC therapy relative to autologous bone marrow. The concern sounds like this: if the cells come from a donor, won't the patient's immune system react then? It is a legitimate clinical question, and the answer lies in the specific biology of HLA antigen expression. UC-MSCs express very low levels of HLA class II antigens, the surface markers that trigger T-cell mediated immune rejection. They also show lower MHC class I expression than adult bone marrow MSCs. This dual low expression profile is what we are referring to when we describe UC-MSCs as immune system neutral. The patient's immune system does not recognize them as foreign in the same way it would recognize a mismatched organ, a donor blood transfusion, or allogenic bone marrow cells administered in a hematopoietic transplantation context. This distinction matters quite a bit in regards to clinical practice. Allogenic bone marrow transplantation in the hematopoietic context, the type used to treat, let's say, leukemia, lymphoma, and other blood cancers, requires tissue matching, immunosuppression, and intensive monitoring for graft versus host disease, precisely because adult bone marrow cells, they do carry a more immunogenic profile. That is not the comparison being made here for the MSC therapy, but the immunological principle is the same. UC-MSC allograft therapy in the regenerative medicine context, joint injections, anti-inflammatory applications, wellness protocols that can be administered to non-tissue matched recipients with a favorable safety profile that has been documented across thousands of administrations. No tissue matching is required, no immunosuppression required, no graft versus host disease monitoring required. Autologous bone marrow in the MSC therapy context carries no rejection risk by definition. The patient's own cells are being returned to the same patient. But autologous bone marrow carries all of the age-related quality limitations that we discussed in the first advantage. The immune system neutral profile of UC-MSCs means practitioners do not have to choose between immunological safety and biological potency. They get both. Let me add one more important note here. When discussing this topic, the favorable immunogenicity profile of UC-MSC allograft therapy is specific to properly sourced, properly processed, properly administered products from the American Association of Tissue Bank accredited, FDA-regulated tissue banks. This is not a blanket statement about every product that carries umbilical cord stem cell labels. Donor screening, processing standards, and lot characterizations are prerequisites for the safety profile we are describing. If your current supplier cannot document all of those, that conversation needs to happen before the next order. The fourth advantage is availability, scalability, and standardization. And I want to be specific about why this matters not just operationally but clinically. Bone marrow MSC therapy in the regenerative medicine office context is inherently constrained by the individual patient harvest. Every treatment requires scheduling the harvest procedure, performing the aspiration, processing the product, and administering the injection, typically in the same session. Every patient is a different donor with a different biology. There is no lot characterization, no viability documentation, no surface marker confirmation, no certificate of analysis. The quality of the product administered is unknowable at the time of the injection. UC-MSC allograft products from regulated tissue banks are manufactured under the cGMP, Current Goods Manufacturing Practice, and GTP, Good Tissue Practice Processing Standards. Every lot that leaves the tissue bank carries full characterization documentation, cell viability percentage at the time of release, surface marker expression confirmation with the CD73-90-105 positive and the CD45-34-14 negative, sterility testing passage under documentation, and certificate of analysis for each lot. When a practitioner orders a UC-MSC allograft from an AATB accredited supplier and receives the certificate of analysis, they know exactly what they're administering. They can document it in the patient record. They can reference it if a clinical outcome is ever questioned. They can use it to set precise patient expectations based on a product with known biological characteristics. That is a clinical protection that bone marrow point-of-care processing cannot provide. And for practitioners who take their professional responsibility seriously, which I expect is every practitioner who's watching this video, it is one of the most important clinical arguments for a regulated allograft product. On the scalability side, a regenerative medicine practice that wants to grow its volume faces a structural constraint with bone marrow therapy. Every patient requires a harvest procedure before treatment can begin. This creates a scheduling complexity, extends the time from consultation to treatment, and introduces a procedural step where patient dropout can occur. UC-MSC allografts are available on demand, on any treatment schedule, without a harvest procedure, removing a significant operational bottleneck from the practice growth equation. The fifth advantage is patient experience and practice efficiency. And while this is operational rather than strictly biological, in a cash pay regenerative medicine office, operational advantages translate directly to conversion rates, patient satisfaction, and sustainable practice growth. No harvest procedure means no additional patient anxiety before treatment, no additional informed consent burden for a secondary invasive procedure, no additional recovery period that delays the patient's experience of the therapeutic intervention, no additional procedural risk that the practitioner must disclose, document, and manage. From a consultation to treatment pathway perspective, a patient who completes an assessment and qualifies for UC-MSC allograft therapy can receive treatment at the same appointment or at their next scheduled visit. no scheduling delay for a harvest procedure, no equipment setup for aspiration, no post-aspiration monitoring before the therapeutic injection can be administered. I've spoken with practitioners who offer both bone marrow concentrate and UC-MSC allograft therapy in their offices, and the pattern that they consistently report is higher dropout at the bone marrow harvest stage than at the UC-MSC injection stage. A patient who is, let's say, initially interested in care will often have second thoughts and drop out once the harvest procedure is fully explained and understood. That dropout does not represent a clinical failure. It represents a procedural barrier that converted a willing patient into a mistreatment. UC-MSC allograft therapy removes that barrier entirely. For staff and scheduling, bone marrow harvest procedure require additional training, specific equipment, dedicated procedure room time, and post-procedure monitoring that UC-MSC allograft administration does not require. A practice that removes the harvest procedure burden can see more patients per day, per week, and per month with lower procedural overhead and higher patient efficiency. I do want to spend some time on the cases where bone marrow-derived stem cell therapy remains a strong and sometimes preferred clinical option because intellectual honesty is the foundation of everything I teach, and a comparison that does not acknowledge what bone marrow does well is not a clinical education. It is a sales pitch. Hematopoietic applications are not part of this comparison and should never be presented as such. Bone marrow transplantation for hematological malignancies, leukemia, lymphoma, myeloma, aplastic anemia remains the gold standard and is a fundamentally different clinical context from what we are discussing in a regenerative medicine office. Any practitioner who encounters a patient for whom hematopoietic stem cell transplantation is being considered should be directing them to appropriate hematology oncology expertise. That is not the comparison that I'm trying to make here. For orthopedic bone regeneration, specifically bone defect repair, fracture non-union, osteonecrosis, bone marrow concentrate has a clinical rationale that deserves acknowledgement. The osteogenic progenitor content of bone marrow, combined with the hematopoietic growth factors present in bone marrow aspirate, may provide specific advantages in applications where bone formation itself is the target outcome. This is a context where the differentiation capacity of bone marrow MSCs may be more directly relevant than the paracrine dominant mechanism of UC-MSCs. For patients with a genuine, considered, and unresolved preference for autologous therapy, not a surface level concern that can be addressed through clinical education, but a deeply held philosophical position, autologous bone marrow concentrate may be the most appropriate choice to preserve the therapeutic relationship. A treatment a patient genuinely trusts and complies with is going to be much more valuable than, let's say, a theoretically superior treatment they approach with reservation. And for practices exploring combination protocols, using autologous bone marrow concentrate alongside UC-MSC allografts, there is a theoretical rationale that the autologous hematopoietic and growth factor environment of bone marrow may create favorable conditions for the allograft paracrine signal, but this is early stage territory. The evidence is not really strong enough yet, and meticulous outcome documentation is essential if you're exploring that approach. The honest summary of when bone marrow remains appropriate is this. In hematopoietic oncology and specific bone regeneration applications, and in patients with unresolved autologous therapy preferences, bone marrow has a legitimate and defensible clinical place. For the chronic inflammatory joint conditions, soft tissue repair, and systemic wellness applications that most regenerative medicine offices treat every day, the comparative evidence increasingly supports umbilical cord mesenchymal stem cell allografts as the higher potency, more standardized, lower burden platform. Now, let me give you the head-to-head comparison and a format that you can use in a patient and colleague conversation. On biological age, bone marrow mesenchymal stem cell quality declines measurably with donor age. The older the patient, the more senescent the cellular population. UC-MSCs carry no donor age variables. Every allograft product comes from a neonatal tissue. On harvest procedure, bone marrow aspiration is an invasive procedure requiring needle penetration into bone under local anesthesia with procedural risks, post-procedure recovery, and documented patient dropout before treatment. UC-MSC allograft therapy requires only the therapeutic injection itself. On MSC yield, MSCs represent 0.001 to 0.01% of nucleated cells in bone marrow aspirate. UC-MSC allograft products from regulated tissue banks are characterized MSC populations with documented viability, not a preparation of predominantly non-MSC cells that requires concentration. On paracrine secretome potency, adult bone marrow MSCs show moderate secretome output that declines with donor age. UC-MSCs consistently demonstrate higher output of VEGF, HGF, IGF-1, bFGF, IL-10, and TSG6, along with more biologically active exosome production. Regarding immunogenicity, adult bone marrow cells in allogenic applications carry a more immunogenicity profile than UC-MSCs. UC-MSCs express low HLA class II antigens, immune system neutral, making allogenic therapy safe without tissue matching for most patients in most applications. On standardization, bone marrow concentrate produced at the point of care carries no lot characterization, no viability documentation, no surface marker confirmation, and no certificate of analysis. UC-MSC allograft products come with full lot characterization at every step. On scalability, bone marrow therapy is constrained by individual patient harvest capacity, one patient, one procedure, one treatment. UC-MSC allografts are available at clinical scale from regulated tissue banks available on demand for any treatment schedule. On procedural burden, bone marrow therapy adds an invasive harvest procedure to the treatment pathway with its own risks, recovery, and dropout potential. UC-MSC allograft therapy is the therapeutic injection. Let me give you the specific language for the conversation that comes up most often. When a patient asks you, "Why don't you use bone marrow?" I've heard that's the original stem cell therapy. Here's how you can answer this. You're right that bone marrow has a remarkable history in stem cell medicine, and for certain applications, particularly blood cancers, it remains the gold standard. For what we're doing in this office, the comparison is different. Bone marrow MSC quality declines significantly as a donor ages, and most of our patients are adults whose bone marrow has been accumulating age-related changes for decades. Umbilical cord tissue gives us access to cells with a neonatal biological profile, younger, more potent, and capable of producing a stronger healing signal than bone marrow from an adult donor. And we can deliver that without putting you through a second invasive procedure before your treatment even begins. When a patient asks, "Will my body reject donor cells? Isn't that the whole problem with using someone else's tissue?" Here's how you can answer this. That concern makes complete sense, and I want to address it directly. Umbilical cord mesenchymal stem cells express very low levels of the surface markers that trigger immune rejection, much lower than adult bone marrow cells. This is why they are referred to as immune system neutral. Your immune system does not treat them as foreign the way it would, let's say, treat a mismatched organ or donor blood. Thousands of patients have received these products without serious adverse immune reactions. We also make sure that every product we use comes from an AATB accredited tissue bank with full donor screening and lot level quality documentation. When a colleague challenges your choice, the comparative secretome literature between neonatal UC-MSCs and adult bone marrow MSCs is exactly quite consistent. MSCs is actually quite consistent. UC-MSCs show higher output of VEGF, HGF, IGF-1, and bFGF, stronger IL-10 and TSG6 production, more robust TNF-alpha and IL-1 beta suppression, and more reliable M1 to M2 macrophage polarization. Add to that the biological age advantage, longer telomeres, lower senescence marker expression, higher proliferative capacity, and the standardization argument. I know exactly what is in every lot administered, which I cannot say for point of care, let's say bone marrow processing. And the case is fairly clear for the application we are treating. Happy to share the specific references. 3 principles to hold in every one of these conversations. Never disparage bone marrow's history. It is real and it deserves respect. Lead with the biological age argument for patients. It is the most intuitive and emotionally resonant. Use Secretome, potency, and standardization for colleagues who want the clinical detail. Let me close with 5 practical takeaways you can apply in your regenerative medicine office starting today. First, bone marrow MSCs have a legitimate and well-earned clinical history, but for the chronic inflammatory, soft tissue, and joint applications most regenerative medicine offices treat daily, the biological limitations of adult-derived harvest-dependent therapy represent a clinically significant disadvantage compared to neonatal umbilical cord mesenchymal stem cell allografts. Acknowledging bone marrow's history makes the UC-MSC case more credible, not less. Second, the cellular youth advantage of UC-MSCs over bone marrow MSCs is not a marketing claim. It is a measurable biological difference. Longer telomeres, higher proliferative capacity, lower senescence risk, cleaner SASP profile with direct clinical implications for secretome potency and therapeutic durability. Every year of donor age that bone marrow MSCs carry is a year of biological accumulation that UC-MSCs do not. Third, the invasive harvest procedure required for bone marrow therapy is not just a patient experience problem. It is a conversion problem, a retention problem, and a scalability problem for any regenerative medicine practice that wants to grow efficiently. Removing that barrier by moving to allograft UC-MSC therapy changes the entire patient pathway. Fourth, the immune system neutral profile of UC-MSCs, driven by low HLA class II antigen expression and lower MHC class I expression than adult bone marrow MSCs, makes allogenic therapy clinically safe for most patients in most applications without tissue matching or immunosuppression. That combination of biological superiority and immunological safety is what makes UC-MSC allograft therapy the preferred platform for most regenerative medicine offices. Fifth, standardization is a clinical argument, not just an operational one. Knowing exactly what you are administering, documented cell viability, confirmed surface markers, certificate of analysis, passage number is what allows you to make defensible clinical decisions, set accurate patient expectations, and protect your practice if outcomes are ever questioned. That documentation exists for regulated UC-MSC allograft products. It does not exist for bone marrow concentrate produced at the point of care. That is your umbilical cord versus bone marrow clinical comparison. 5 core advantages of UC-MSC allografts across biological youth, paracrine secretome potency, immunogenicity profile, availability and standardization, and patient experience and practice efficiency, with an honest acknowledgement of where bone marrow remains clinically appropriate and the specific language for your next patient and colleague conversation. This is episode 3 of the Select Regen Solutions Clinical Science series. Coming up next, how to evaluate your umbilical cord stem cell product supplier, the specific questions you must ask, the documentation you must see, and the red flags that should stop any purchase conversation before it goes further. That video is next. Subscribe so that you do not miss it, and share this video with any MD, chiropractor, or nurse practitioner in your network who is evaluating their regenerative medicine product choices or who has ever had a patient ask them about bone marrow. If your regenerative medicine practice is ready to go deeper in allograft product selection, supplier evaluation, patient communication systems, protocol design, or practice growth strategy, that is exactly what Select Regen Solution does. The initial consultation is complimentary. Call or text 586-524-8456. email Roy Picard at selectregensolutions.com or visit www.selectregensolutions.com. I'm Dr. Roy Picard. Thanks for watching, and see you on the next one.